Thank you, Clement. A couple of years ago, when the 3-year follow-up of TVT study was published, and suddenly people started paying a lot of attention to the fact that they reported higher failure rate in the trap, and that was the time everybody started wondering and trying to think to use the more often tubes. That was the time that Glaucoma Society of India has asked me to prepare this talk. I'm not sure whether it really makes the same impact now, but anyway, that is the talk allocated to me. So I'm going over it. So if you look at the glaucoma surgery, it has been evolving last 100 years, and trabeculectomy is the most widely done procedure. It has a good staying power. Most of the newer surgeries like drainage implants and others are becoming more often done surgeries. Is a trabeculectomy gold standard? It's widely done surgery, gives good control, but has potential side effects. But still, trab is commonly done because there is no ideal substitute. There are two major issues with the trabeculectomy we all are aware. Just to recap, scarring is the most common cause of the failure. We tend to use the antimetabolites to reduce the scar. The two is that which we face in everyday clinical practice. So an ideal procedure should be cost effective, should have least complications. Unfortunately, we do not have any such surgery yet. Because of that, we tend to do the trabeculectomy still very often in our clinic, and newer procedures are becoming popular, but it has its own drawbacks. So with this background, TVT study, what does it mean to us? My information is from these publications that includes the 5-year follow-up data of the TVT study. The aim of the TVT study was to compare the safety and efficacy of non-valve tube with the trap with MMC in patients with the previous surgery. It is a well-done randomized study. They have used the 350 Barwalt implant, and they have done the trabeculectomy with the mitomycin C using 0.4 milligram per ml for 4 minutes. As far as we are concerned, we do not have access to Barwalt, and majority of us don't use the dose of the mitomycin C. We cannot extrapolate entire information from this data to our clinical practice. The strength of the study, randomized control trial, baseline characteristics are very well documented and very good follow-up. The limitations, one should remember, results cannot be generalized. Low incidence of certain complications and small size of subgroups limit the power of the study. And limbal blast flap with the 5 minutes MMC was used, and present trend is to use fornix blast flap the lower dose of the mitomycin C. Probably subgroups of patients had failed trap with MMC. There was a bias towards the tube, and possibly strata was created to facilitate data analysis. And the tube surgery, if you look at it, it was surgeon's technique. There was no uniformity in the technique that was followed. And more so with the trabeculectomy, and there some were limbus, some were fornix. The MM's application was no uniformity. The same way the limbus waist flap, the closure of the wound was not very uniform. And if you look at the reoperations for the glaucoma surgery or complications, any additional surgery requiring a return to the operating room was considered as a reoperation. That includes cyclodissection, vitreous trap with injection of the intravitreal antibiotics, etc. On contrary, any intervention in the outpatient like needling procedure, ESC reformation were not considered as the reoperations. This is the 5-year follow-up. If you see the cumulative probability of failing, it was more with the trabeculectomy group than the tube group. If you see the reasons for the failure, and as a clinician, my main concern was that persistent hypotony, which was higher, that is less than 6 millimeters of mercury, was the trabeculectomy group, and that has tilted the failure rates grossly between the two. But as a clinician, not a pressure of hypotony that is less than 6 millimeters is always detrimental to the patient. On the contrary, in advanced glaucomas, many times as a clinician, we all accept it works to our advantage. Maybe if you can reclassify, maybe the failure rates, I don't know, maybe equal between the two. If you look at the complications, early complications, again we do anticipate some amount of leak from the edge, especially with the fornix-based flaps, with the trabeculectomy. And majority of the complications, early postoperative complications in the trabeculectomy group is that small leaks that has tilted the rates differently between the two. If you look at the late complications, the persistent corneal edema and things like that, it was significant in the tube group. And similarly, if you look at the reoperations, penetrating keratoplasty and vitrectomy was much higher with the tube groups. The overall failure rate was higher in the trabeculectomy group. If you relook at it critically, it may make a difference. It may not make a difference between the two. The reasons for failure were distributed similarly between the treatment groups. Both tube shunt surgery and trabeculectomy with MMC were effective in lowering the intraocular pressure. The overall success rate was higher for the tube group, but the rates of the complete success, if you take into the definition into consideration, were not statistically different between the treatment groups. Does not demonstrate superiority of one surgery over the other. Use of bar welt only was used. In our situation, mainly we all use the Ahmed. Recently, we got the RD implant, which the sample is, the design is similar to the bar welt. So we will have an access to bar welt type of the wall in the future. And one should remember glaucoma control is not just by the IOP alone. You have to look at the other parameters like the disc changes and the visual field changes. It excludes several types of refractory glaucomas, so we cannot generalize these results for all. And there was a lower threshold for tube surgery. Many of them had a prior clear corneal cataract surgery in the group. From a developing country perspective, it will definitely, the tubes will definitely increase the cost. One can do a tube in a failed trap. Trap following the failed tube will be difficult or maybe impossible, and putting a second tube will escalate the cost. At present, we do not have an ideal procedure for the glaucoma surgery. Non-blood procedures are safer but not very effective. Tubes do not have any edge over trap, at least when we're talking about the primary traps or even the second trap. Trap is still widely done surgery in spite of its limitations. Thank you. Thank you very much for your kind attention.